I'm going to go ahead and kick things off here as folks continue to enter in. It's wonderful. This is being recorded, so anybody can play it back after this time and watch. I'll send the link out later on this evening once it is posted. I want to take a moment and introduce myself. I know some of you are familiar with Lending Hearts, some of you are not. My name is Vaso Paloris. I'm the founder and executive director of Lending Hearts. And these open discussion topics are ones that we like to do several times throughout the year and explore different topics that are of interest to everybody. This one has a particular interest to myself, and I know to many of you as well. Thank you very, very much to Dr. Kirsten Rose-Felker, who will be our speaker this evening. She's a pediatric cardiologist and the director of Pediatric Cardio-Oncology at UPMC Children's Hospital of Pittsburgh. We thank you so much for joining us this evening and addressing this topic with us. So many of you gave questions in advance that she has incorporated into this evening's presentation. But as we go through, please feel free to put questions in the chat, open up, ask them at the end, whatever you feel comfortable. We're very casual here, and like for everyone else to feel comfortable as well and sharing their questions along the way. And all of this, as I said, will be shared with you after the presentation. But if you have any questions in the future for Dr. Rose-Felker, perhaps I can pass those along. Whatever she prefers, I'm happy to do. So without further ado, I'd like to turn things over and we can start this evening's information.
Thank you so much, Vaso, and thank you everybody for joining. I'm very excited to see how many people are interested in their heart health after cancer treatment, and this is a topic that is very near and dear to my heart. So we'll go ahead and get started, and please feel free as I talk tonight to put questions in the chat, to raise your hand, to speak up. This is really meant to give you any information or answer any questions you might have. Okay, so we'll begin. So what I hope to cover tonight is why cancer survivors have higher rates of heart disease. I think this is something that a lot of people are made aware of, but maybe not given information or the tools to understand better if they're at risk or how to manage it, how to recognize symptoms of heart disease and make sure that you're getting the recommended screening for you, how to prevent heart disease and be the healthiest survivor out there. And then especially, I want to leave some time at the end for your thoughts and questions. I was so impressed with the questions already sent in tonight, and we'll go through some of those at the end. But I'm really excited to hear what you have to say. Okay, so my background, this is important. I am not an oncologist. I'm a pediatric cardiologist, and I have a special interest in cardiac issues facing patients that are being treated for cancer or who have survived childhood cancer. And this is something that's been an interest of mine for a long time, and it's a growing interest within the cardiology community. And I think really to the benefit of people that have been treated for cancer, there's a lot more communication than there used to be between these two disciplines. And I think a lot more effort out there to help prevent this. I treat patients with heart dysfunction, sometimes patients who have advanced heart failure or need heart transplants. But a lot of the time I spend with cancer survivors is screening anyone with increased risk of heart disease and helping them know kind of where they fall along that spectrum and what they can do to manage it. And my personal mission is that childhood cancer survivors have long, happy, and healthy lives and receive the best cardiac care that's out there. So what do we know about cardiovascular health in cancer survivors? We know that there's increased risk of cardiovascular disease, and that really can come from kind of two separate types of risk factors. Some are things that we can do nothing about. The cancer treatments that you receive were important to save your life and treat your cancer. And so that's kind of what we begin with. The thing that we can change are these modifiable or lifestyle risk factors. They're sometimes called traditional cardiovascular risk factors, and everybody's heard of them. Those are things like high blood pressure, diabetes, lack of physical activity. And so we'll go through that a little bit as well. And then I know from my practice that with early identification of changes and risk management, survivors are healthier. And I think some of the data that we'll present today, I hope will be so much different in the future due to both changes that oncologists are making in cancer treatment protocols, but also to better screening and monitoring. So what types of heart disease? There's a lot of things that get thrown out as heart disease. And I think a lot of us, when we think of heart disease, we think of coronary artery disease that, our grandfather may have had. But there's a whole bunch of different heart diseases that may come up as a result of cancer therapy or just in cancer survivors in general. The most common of which is cardiac dysfunction. And this is when you have decreased squeezing or filling function due to heart muscle damage. And we'll go into a little bit of why that can happen with chemotherapy. Most commonly in cancer survivors, this has no symptoms at all, and it's called asymptomatic left ventricular dysfunction. And the reason that echoes might be part of your follow-up for long-term care is to try to detect changes in this, because if we find these changes early before symptoms develop, then we can really change that course. If there's persistent changes in the heart function, that's what we call cardiomyopathy. And there's a bunch of different types of cardiomyopathy, some that are inherited, some that are a result of different exposures that we may go through in lifetime, whether it's a viral illness or a toxin like a chemotherapy. Congestive heart failure refers to a set of symptoms people have when they've developed poor heart function. And typically this is pretty bad heart function. We'll talk about what's considered normal and what's not, but this is usually more advanced. And it's after someone has had known cardiomyopathy that these symptoms develop. Although in rare cases, it can develop quite quickly and people may have symptoms first. So we'll talk about how to recognize that. Arrhythmias refer to abnormal beats or abnormal heart rhythms that can range from simple and safe to dangerous and requiring treatment. And that's something that any cardiologist can help direct you to resources if you have any issues at all. And then heart valve issues may be more common in those that are exposed to high-dose radiation therapy that affected the chest. So this is a kind of a sobering slide. And again, I think part of the thing that I think is going to change as time goes on. So this slide comes from a study from the Dutch Childhood Cancer Survivor Group, and it looks at kids that were treated for cancer in the Netherlands between the 1960s and 2002. So I think first to know is that this is a pretty wide range of patients treated with all kinds of different regimens, a lot of which wouldn't be used for the same cancer in 2002 that they were used for in 1963. But this graphic over here it differentiates patients who received no cardiotoxic treatment. And that means when we refer to cardiotoxic treatment, this is typically certain types of chemotherapy, including anthracycline chemotherapy, which is still kind of a mainstay in most types of cancer treatment, and radiation that includes the heart in the field. So in the average patient, you have to think about somewhere in between these two lines. By 40 years after diagnosis, about 4.4% of survivors developed heart failure. And remember that's far down the line after some initial dysfunction is detected on an echo. And by 50, that number goes up to 5.3%. I think a couple things to remember about this graph is we think about having chemotherapy and then being done. It's important to know that these heart risks can actually increase with time after cancer treatment. So we see that more and more people are affected as they're later out. And a lot of that will come from some of the things we'll talk about, which are those kind of other traditional risk factors that we pick up, like high blood pressure or other things. Those that were treated with cardiotoxic therapy have almost double the risk of the average here at 10.6% developing heart failure by 40 years after treatment. And if we look at US statistics, according to a study from St. Jude, which is our largest population of pediatric cancer survivors, we know that survivors has a 6-fold increase of developing heart failure when we compare them to siblings. So this is really something, even though the numbers here are small, this is something that we have to take really seriously and really improve as a community. And so I want to make the take home after seeing that scary slide that most childhood cancer survivors, even those treated with higher risk treatments, don't develop heart failure. This is a small percent, but I hope that as time goes on, that number becomes smaller and smaller and smaller. So what are the things that can increase your risk? We talked before how there's things related to your treatment or things that are related to more traditional heart-related risk factors. Treatment-related risks are certain types of chemotherapy, radiation therapy that's directed at the chest, but some that it can include the heart in the field, even unintentionally. And that can be mediastinal, lung radiation, spinal radiation, abdominal radiation, which affects the large vessels under the heart, or reflected doses. And then total body irradiation if it's over a certain dose. Typical patients who have a bone marrow transplant would have only a small dose of total body radiation. Patients who are treated at a very young age when the heart is still developing have higher risk, and those that are female have higher risk, and we think that may be related to increased risk of pregnancy over a lifetime, which is an independent stressor on the heart. Lifestyle risk factors, we all know about those. These are the ones we see on TV. High blood pressure, physical inactivity, high cholesterol, smoking, diabetes, excess weight. While it can be hard, these are all things that we can control, at least to some degree, to stay healthier. So what are the specific cancer-related risk factors or treatment-related risk factors? Anthracycline chemotherapies, there's a bunch of them in this class. Doxorubicin and daunorubicin are the most common. Mitoxantrone is a slightly different class of chemotherapy, but is also quite cardiotoxic. And these are typically dose dependent, meaning your oncologist is keeping track of the total dose that you had over the course of treatment. And then that number over the lifetime is what we look at for the risk of cardiac disease. This type of chemotherapy specifically affects an organelle that you might remember from high school biology called the mitochondria. That's like a little powerhouse of the cell that uses up a lot of oxygen and helps us generate energy. And as you can imagine, the heart is rich in those mitochondria because it's a huge producer of energy for the body. And so individual heart cells may be damaged or even killed by the anthracycline chemotherapy. And what typically happens is the remaining heart cells around it kind of take up some extra slack and do some extra work. But over time, other things that can affect the heart can make those tire out a little bit too. And eventually we might see on a global level that there's a change in systolic or squeezing function of the left heart or the left ventricle, which is the side of the heart that faces the most amount of pressure and does the most amount of work. And so typically, while the damage can be to the whole heart itself, that's the place where we see it. And the good thing about echo is that it's really good at assessing left ventricular function in most people. Radiation therapy can affect a whole bunch of different things. It can cause inflammation of the lining around the heart called the pericardium. This can lead to things called pericardial effusions or fluid collections that sometimes need to be drained, heart rhythm conduction problems like heart block, coronary artery narrowing or stenosis, valve thickening, or muscle damage. And these can be followed with echo or electrocardiograms or EKGs, or even other tests like cardiac MRIs. Other newer medications can affect the heart. We know that in adults treated with certain medications like tyrosine kinase inhibitors or MEK inhibitors, there are cardiac effects, and we're really still learning what the effects are in children. But these are things that likely your team, if there's ever been a published effect related to the heart, there's some surveillance that's going on for your heart to keep you safe. And then most centers, this is a really important thing to know, will provide a written treatment summary with doses and dates of your treatment. And so if you don't know, which is the most common thing, you can ask for that treatment summary and you can have a physical copy. And if you go to see a cardiologist or you're going to a primary care doctor to establish care, you can bring that. And I'm going to direct you to a website that's really helpful in helping to look at what you got and what you need to look for in case your provider is not as familiar with it. There's also this St. Jude cardiovascular risk calculator that's available online. you're welcome to use this link and do this calculation. I can tell you, I don't often do this in my clinic. I find that it tends to overestimate risk a little bit, and it can be a little bit scary. I think they've made a couple attempts to try to make it more precise. And if you see on the website, there's a bunch of different calculators, some that take into just your cancer treatment alone, and then newer calculators that take in other risk factors as well. So how do you know if you have heart disease? Every single person who's treated for cancer should have a yearly evaluation by a provider that's familiar with their treatment and aware of possible late effects. This doesn't necessarily need to be an oncologist or a survivorship specialist, although those people are phenomenal in knowing this. It can be any provider who's just aware of these guidelines, and I'll show you how to access them. You can even teach your provider about them. And minimum requirements are physical exam and vital signs, including a blood pressure. And then depending on your treatment, you might need echocardiograms on a regular basis, lifelong, to assess heart function. You might get EKGs to assess your heart rhythm, or you could know about heart disease by having symptoms. Although, again, that's more rare in our childhood cancer survivors. This is the website that I'm going to refer to a couple different times during this talk because it's so good. Survivorshipguidelines.org is a resource that's published by the Children's Oncology Group, which is, I'm sure you're all aware of this group, but it's a panel of experts from the top centers across the United States. And right in the beginning of this statement, they state their goal, which is to increase the quality of life and decrease complication-related healthcare costs for cancer survivors. And there's a new version that's released every year. There was a version just published that was updated in October of this last year. And you may hear from your survivorship specialist or your primary care doctor that your echo frequency has changed or something based on this document, but you can look it up yourself, and it's a really actually relatively straightforward to navigate. The good news also is that your oncology group was thinking about this long before they even met you or before they even ordered any of these doses. The oncology community has been working to reduce doses in a safe way for a long time and continue to do studies. We're part of studies at Children's looking at ways to make certain treatments safer. They can use medications sometimes with anthracyclines, medications called dexrazoxane, or the trade name is Zinacard, that can be sometimes infused right before a dose of anthracyclines. And then surveillance echoes, meaning when we say surveillance, we kind of mean there's nothing wrong with your heart. We're just looking for these mild changes because we know that if we act on a mild change, we're a lot more likely to be able to preserve the global heart function long term. And this is the new thing, the new guideline statement from the Children's Oncology Group about echo screening. This shows you the anthracycline doses here. And remember, we talked about cumulative doses, meaning your whole dose over the course of treatment or multiple treatments, radiation dose, and then that will determine the frequency. So I think the major change with this October publication is that patients that were treated for standard risk B-cell ALL, which is typically about 75 milligrams per meter squared of anthracyclines, who don't get radiation, may no longer need lifelong echocardiograms to monitor function because the risk is thought to be low. But if you're treated for Ewing sarcoma or osteosarcoma or AML, and you have higher doses of anthracyclines, you may need an echo as frequently as every 2 years, just kind of keeping an eye on that heart function, make sure nothing has changed. So what does an echo show? It's an ultrasound of your heart, which everybody here knows because they've had one or know a loved one that's had them. This shows how well the heart squeezes, or the systolic function of the heart, looks at all the valves, and it looks at the vascular connections of the heart. It's safe in that it doesn't have any radiation exposure. They provide excellent information, and they're read by a cardiologist rather than a radiologist. And there are very clear published guidelines from cardiology communities on what we should be doing to assess for cardiac disease in cancer patients. And so if you're going to a reputable center, there should be a very specific echo protocol they're using to look for really any subtle changes. What is important to know here is the cardiologist that's reading your echocardiogram will likely never meet you, nor will they review your chart to know your specific risks. And so it's really important that the person who's ordering these echocardiograms, which is usually going to be either your oncologist or a primary care doctor, is relaying the report to you, but also like really kind of looking at it in detail. And with most electronic medical records now, you should be able to access the reports yourself. And if you have any question about changes or things that are mentioned on that echocardiogram, because there's a whole lot of things that it gives us besides just function, you can always ask to see a cardiologist or ask if they can contact a cardiologist to see if it's necessary. So I think this is important to know too, because this is one of the most common pitfalls of measuring heart function. It sounds like it's this super precise scientific way of knowing how much the heart squeezes. And it is precise to some degree, but I'll tell you, we know that if 5 different cardiologists read an echo, you will probably get 5 different measures of heart function, usually within 5% of one another. But if you are seeing a change from one echo to another, that's a couple points in percentage, I wouldn't necessarily fret over that. It may just be a difference in the way it's read. And that's something a cardiologist can help you with by actually looking at the images themselves rather than the report. So the fractional shortening is something we might hear about. That is the percent change in the heart when it squeezes. So it's literally a fraction. You look at the heart. This is the heart kind of flipped to its side where you see that circle. We think of the heart like this. If you flip it like this and cut it through, this circle here, we drop a line through this and we track the wall motion. So this is the size of the heart when it's fully filled. This is the size of the heart when it's fully squeezed and has ejected. And we subtract the blue line from the red line and divide it by the red line. That's called fractional shortening, and normal for that is above 25%. Ejection fraction is the number you might hear more frequently. That's the one that we tend to use in cardiology. It's a little more precise because we know the heart is more than just a 2-dimensional thing with lines. It's it's something that's capable of holding fluid, and so we should use volume to measure it. And ejection fraction is it's the same fraction or the same equation using the volume of the heart, maximally filled versus emptied, divided by maximally filled. And normal is over 53% in adults and over 55% in kids. And so one thing I usually tell families is, I think we think about, oh my gosh, it's, my heart function is only 54%. Well, nobody's is really better than 65%. And so it's not like this is on a scale of 100. Most people's ejection fraction fall within that 55 to 65% range. And it's normal for it to have a little bit of variation, but we really want to follow trends. And if it's dropped more than 5 points, then we might want to keep it a closer eye on it. And so think about these more as an estimate of heart function than this super precise measure. So what doesn't an echo show? It doesn't tell us about the rhythm. So if you're having palpitations, skip beats, an echo won't be helpful for that, and you'll need more testing. Doesn't tell us about coronary artery plaques or the risk for coronary disease. That can be CT scans can tell us that, lipid panels can tell us. And if you're having any symptoms related to your heart, it's best to discuss it with a cardiologist because they're going to help. There's all this testing that can be ordered. They're going to really help you find the most appropriate test and the most relevant test instead of putting you through all these tests that might still not be able to identify your symptoms. And so what if you have one of these surveillance echoes that's abnormal? I think first of all, don't panic. While only a small number of survivors develop true heart failure, many more will have an abnormal echo at some point. And this really, you should use this as an opportunity to consider additional testing, manage other risk factors, maybe increase the frequency of your checks. And we know that if we find these mild changes in the beginning, that they're often reversible with medications, and early detection gives us the best chance. So don't skip those surveillance echoes. What are some other tests that are out there? Exercise stress tests. This guy here is having a stress test. We do these at Children's many times a day. Wear EKG leads and run on a treadmill. You can see he has a blood pressure cuff. There's also exercise stress tests where you have to wear a mouthpiece that collects data about your cardiac fitness. But in general, these look for any EKG abnormalities that could assess poor blood flow to a part of the muscle, abnormal muscle health, abnormal blood pressure response to exercise. And so these might be really helpful tests for survivors. Cardiac MRI is better at detailing the actual heart muscle itself and can tell us if there's scarring in the muscle. And in some patients, echo it's really hard to see. And we say that we call them echo windows, or essentially we're looking through the lung to look at the heart. It might be hard to see. And so MRI is a little bit more precise in its ability to measure function. This little guy here is wearing a Holter monitor. That is the Holter monitor collects every heartbeat over the length of time that you wear it, whether it's 24 hours, 48 hours, up to 14 days. And that's good at detecting if you're having palpitations that are somewhat frequent, or that are somewhat predictable. The Holter can be helpful for that. 30-day event monitors may look the same. Often those are taken on and off, and you would have it available to you for 30 days. And then there's even some newer monitors that are available like commercially through your phone and stuff, that you could talk to someone about. In terms of lab work, there are certain lab markers that look at heart stress. In kids that are cancer survivors, we don't routinely do these, largely because there's really not a great benchmark for interpreting them. We may do them to assess in somebody that has had a change in function, or we may have a baseline measurement, and if there's a symptom that's coming, we may check again. But routinely, troponin and BNP, we don't typically measure. Cholesterol screening should be measured now in every adolescent at some point during childhood. And we manage cholesterol abnormalities a little bit tighter in survivors than we do in the general population. So this should be something that's regularly done, and fasting is best. And then what about those other modifiable or lifestyle risk factors? That same data, that St. Jude Childhood Cancer Survivor Study, that's that largest American study about childhood cancer survivors. The stats from this slide are patients that were treated from 1970 to 1999. So again, older than a lot of the people that are, on this call today. But this shows that survivors are almost twice as likely as their siblings to have hypertension, diabetes, 1.5 times more likely to be taking medications for high cholesterol, and they're less likely to meet guidelines for physical activity. And we know that when we put this on top of the risk factors related to treatment, that it's more than additive to increasing risk for heart disease. So this is really what we're trying to control. And even from childhood, the better we can control these things, the better off we are in the end. What if your provider mentions one of these things? I think most importantly, it's try not to take it as a judgment statement. Plenty of providers are on medications for high blood pressure. Knowing about the risks is the best way to prevent issues down the line. And exercise is really important and increasingly important. I'll show you some data at the end. And very rarely do we limit people in terms of what they can do. So this is the kind of call to action. What can you do? How do you avoid heart disease and ensure the best heart health? I think number one, just showing up to this, listening, making yourself aware of your risks, being informed about your treatment. That's the most important thing you can do. And then it's just kind of little steps from there. So this is another plug for survivorshipguidelines.org from the COG. There's 3 handouts that I love for heart health, and I give these out regularly in clinic. There's one called Preventing Cardiovascular Complications, Keeping Your Heart Healthy, this is an example of that. I think it's 7 pages long. And then Nutrition and Physical Activity, and it's all targeted at cancer survivors and uses data from all these different studies that we have. You can ask your team to meet with a cardiologist if you're interested in it. You can pay attention to your blood pressure and weight. ask your oncologist about what it was about your treatment that could affect your heart. Did you have any of these that we see here, or what do you need to worry about? And then symptoms. I think I stress the word possible symptoms of heart disease here because it's important to know that all of us at some point have had any of these symptoms and may or may not have heart disease. But if you're repeatedly experiencing any of these or even experience them in a profound way, it's worth mentioning to a provider. So this can be in kids, the most common symptom of the heart not working well is actually stomach issues. Nausea, vomiting, unexplained weight loss, chronic stomach pain. In adults, it can be symptoms more with exertion, like trouble breathing when you start to exercise, even trouble breathing at rest, needing multiple pillows to prop yourself up on when you sleep, swelling in your ankles, belly, or face, abnormal heartbeats or heart racing, and then trouble doing the things that were usually easy for you in the past. So just keep an eye on any of those things, and it's worth just chatting with your provider if you notice a change. And what can you do to stay healthy? As I mentioned before, exercise is generally safe and encouraged. My goal is to try to get everybody to exercise because there's so many benefits to it. If the only reason you shouldn't exercise is if you've been told that your cardiac testing is abnormal. And usually then you should be seeing a cardiologist who's helping you decide what limitations you can have. Typically, the main limitations that we put on people are limitations that most people should follow anyway, which is avoiding extremely heavy weights, like single rep maxes or deadlifting. But in general, strengthening and all forms of cardio are safe and very beneficial for people treated with cancer. Increasing intake of whole fruits and vegetables, whole grains, legumes, all of these things are good for our heart. Limiting sugary drinks, quitting smoking, and then limiting alcohol to what's considered healthy are also good idea. So we talked about it's, more than midway through January now. It's never too late to kind of pick up some good habits in the new year. I think remembering starting out slow and just even little things can really make a big difference to your heart health. Trying to track your steps on your watch or on your phone and just try to get a little bit more every week. Pick things that you like. I have patients that tell me that they want to start running, but they hate running. Well, then it's not going to work. So pick dancing or a exercise class with one of your friends or a HIIT workout that you like on YouTube. There's so many things that are available. I just tell my patients, I want you to get sweaty as many times a week as you can, doing whatever you want to do that's fun. And you want to alternate strengthening and cardio or aerobic exercise. And then most importantly, if you're in pain, especially chest pain, dizziness, or have trouble breathing when you're exercising, let your provider know and stop until you are able to talk to them. The American Cancer Society has a bunch of different statements on exercise showing that it reduces the risk of secondary cancers or cancer recurrence. Adults are recommended to exercise for at least 150 minutes a week, which seems like a lot. But that can be even like vacuuming, gardening, doing chores around your house, or 75 minutes of vigorous or sweaty exercise, like running aerobics or heavy yard work. And then kids need even more, 60 minutes a day and at least 3 days a week of vigorous activity. There's a great statement. There's a link at the bottom of this slide from the American College of Sports Medicine. There's a really great statement on exercise here. And they pull together all of the studies looking at exercise in cancer survivors and show that there's strong evidence that exercise improves physical functioning, fatigue, anxiety, depression, health-related quality of life. And they recommend some different combinations of aerobic and resistance exercise, and even just breaking them down one at a time here, and then moderate evidence for other things as well. And just practical things, we all know this, but just parking at the far end of the parking lot, get a couple more steps today. Find somebody you like to talk to on the phone or at your workplace or school that you could take a walk with at a time you'd be sitting, taking the stairs when you can, stretching when you're at a desk all day, getting your dog out for a walk, doing something around the house before you sit and relax, and then planning stuff that's fun to do on weekends and your time off. There's some specific resources for cancer survivors. I have not confirmed this with the Sewickley Valley YMCA. I meant to do this today. So if anybody hears, you can always let me know. But the Live Strong Foundation has a program through the YMCA that's a 12-week program designed to get survivors back on their feet. And I don't think there's a limitation on how long this is after cancer therapy. They provide free or low cost a customized regimen with a certified fitness instructor to try to help with rehab after cancer treatment. And oftentimes family members will get a free or discounted membership at the same time. And if you look on the website, Sewickley Valley is listed as a participating program. So it may be worth checking that out. I can't stress enough the survivorship guidelines. They have so many good information in there, both to help your provider if they're not quite sure how to steer you, or for your own information with links at the end if you keep scrolling all the way down. And then that American College of Sports Medicine guideline that I showed. You can always see us. I'd be happy to see anybody. I'm a pediatric cardiologist, so I do best with patients when I meet them when they're less than 25, but I see a lot of young adults, even a little bit older than that, in my clinic because they tend to still follow with our survivorship program at Children's. There's an adult cardio-oncology program as well. This is Dr. Harenstein. Dr. Joshua Levinson is the current director of the adult cardio-onc program. We have a good working relationship and a referral program in place to get our survivors over to the adult program. And if you ever had questions or needed to get in or were having trouble, you can always reach out to me and I'm more than happy to help. But that's on the UPMC website and you can Google either of these two things. So just to conclude my talk today, I think we've shown that heart disease can be a real issue for childhood cancer survivors, but I hope as time goes on, this is going to be a distant memory. Early detection and treatment of heart-related issues and risk factors is the key to changing this. And if you have questions about your heart health or you're having symptoms or you need more information, remember there's people out there that are waiting to help you if you need it. So don't be afraid to ask for a referral or send an email. I'm more than happy to help. So that's all I have today. I thank you again so much for giving me a chance to talk a little bit. And Vaso sent me some really great questions from the audience. So I don't know, should we take any questions from the chat or go through these now?
One in the chat, whatever you'd like to do.
Yeah, maybe we'll go through these first and then feel free to keep joining in the chat if you feel like I'm not answering them, or just speak up if you have questions. So these are questions that were submitted before the talk, which I really appreciate and I was very impressed by. Should echoes or EKGs be done throughout treatment routinely to monitor early warning signs? That is a really great question. That is a question that your oncology team will answer, because the cardiology team will only get involved typically unless your oncology team refers you to them. So most cancer treatment protocols, especially if they're using treatments that could affect the heart function, include routine surveillance or kind of like checking for problems as part of the treatment. And then it would generate a referral to a cardiologist if there's a problem or an abnormality. If you're having symptoms or something, or there's a change, you may go off of the protocol and may need additional things. Or if you have other risk factors going into treatment, like say you had a history of congenital heart disease or a bicuspid aortic valve or a family history of heart disease, that's really important information to share with your oncology provider, because then it might make your surveillance strategy just a little bit different than other people. So absolutely, every patient that is treated with anthracyclines gets an echo before they start any treatment. And so oftentimes that's what we have as a comparison. And then oftentimes they'll get it throughout therapy if it's something that's cardiotoxic. And then most patients will also get an echocardiogram after completing cardiotoxic therapy and at certain intervals. So you can always ask your oncologist if you have questions, or that survivorship guidelines is a great link if you are wondering if you need them long-term. Routine lab work as like BNP and troponin. This is a really good question and a hot topic. I think in adults, it's becoming a little bit more routine to do things like troponin or BNP before cancer treatment, but that's because adults tend to go into cancer treatment maybe having heart disease already. Most of the kids that we take care of come into cancer treatment with no heart disease. And so there's not a great precedent for monitoring things like BNP or troponin. We use it a whole lot in kids with heart failure, BNP especially. But there's not a great place to use it routinely unless we have concerns. The routine lab work that should be done is at some point a fasting lipid profile or a cholesterol test, because as I mentioned before, cholesterol should be treated a little bit more aggressively if you're a cancer survivor than in patients who haven't been exposed to cancer treatment. And so lipids, I would say, is a yes. And then BNP and troponin is kind of like on an as-needed basis only at this point. Sports or exercise that are appropriate. I would just venture to say, if you have not been told that you have heart disease, anything that you feel like you can do is safe and appropriate for you. There's really nothing that we restrict. There is a caveat in the survivorship guidelines that say if you're going into very highly competitive sports, it may be worth a cardiology consult. Sometimes that's where we do things like an exercise stress test, or do a little bit more to kind of just assess the heart under a little more pressure. But in general, exercise is safe and appropriate. And even our patients with heart failure for other reasons, until that degree of heart failure reaches a certain point, we still want them to stay physically active. So really great question that you can talk to your oncologist about based on treatment, or you can ask for a cardiology consult if you're interested in being an ultra marathoner or varsity level sports or collegiate sports, but we have a whole bunch of athletes in our clinic. Warning signs that physical activity is too much or you should worry about the heart. The major ones would be chest pain that occurs only with exertion and repeatedly with exertion, dizziness with exercise, significant trouble breathing with exercise, inability to do things that you used to be able to do easily beyond just being out of shape a little bit at the beginning of basketball season or track season or something. I would say really chest pain with activity, dizziness with activity. Those are the big ones to let us know about. If you're unsure, you can always ask your primary care doctor or your oncologist, and they'll be able to guide you to know if you need a cardiology consult or other testing. And then the last one's a really good question, kind of putting those new published guidelines into work. As someone who's had doxorubicin in leukemia treatment, what can I do other than screening to ensure the health of my heart? So we talked about how some patients with leukemia may not even need these routine echocardiograms anymore if they're feeling well and they don't have symptoms and they've had low dose exposure to anthracyclines. Things to ensure the health of your heart are really all of those risk factors that you hear about related to lifestyle, making sure you're not smoking or vaping, trying to be as physically active as you can, trying to keep an eye on things like weight and body mass index. A BMI is not a perfect measure by any means because it doesn't separate fat from muscle, but I think it's the best predictor we have out there for predicting acquired cardiovascular disease. So I would say exercise and managing all those things, not ignoring if someone tells you your blood pressure is high or your cholesterol is a little bit high, really just using that as an opportunity to kind of take control of your health from a heart standpoint a little bit better. So really awesome questions. And I'm going to open up the chat now. Okay, so Catherine asked, can red devil chemo cause delayed heart problems, or would it happen right after the chemo duration? Really good question. So red devil chemo can be another name for the anthracyclines, which people may remember can turn body fluids red, and people will remember that because it can be a scary chemotherapy. There's actually two types of cardiac dysfunction that can happen with anthracyclines. It's not uncommon that there's some initial toxicity, but oftentimes that can be because there's other things going on at the time of cancer treatment. Sometimes severe anemia, fevers, really bad bacterial infections. These things can exacerbate any mild heart dysfunction and really can make it look bad. The good thing for those patients are that's the most likely to be reversible. The more, the thing that we worry more about is the late dysfunction. So it can happen long after chemotherapy is given. And if you remember that chart, Catherine, that risk of heart disease increases over time, probably also because we develop other risk factors for heart disease, but that the longer you are from treatment, the higher the risk actually is for developing decreased squeezing function. So great question. And then Lauren asked, for a childhood cancer survivor, would having an AED nearby at home or at work be helpful? Always AEDs, I think, are helpful. They can be a little bit tricky. Number one, they're pretty expensive, which means they're hard to buy outright. And number two, you really have to weigh on insurance, which I do on a regular basis to try to help provide them for people. There's things called Project Atom, which it's a nonprofit meant to increase AEDs around public places like workplaces, schools, athletic facilities for anybody. Most childhood cancer survivors tend not to have the type of scary ventricular arrhythmias that an AED would be used to treat. And so while I think it's really helpful, I think for childhood cancer survivors, even more helpful would be thinking about like keeping up your routine surveillance care. And then for anyone with heart disease that we worry that is at risk for those scary arrhythmias, that's when your doctor can help you advocate to maybe have your own AED or make sure there's one nearby you. That's a great question too. And then if there's no other questions, which I'm open to hearing, I had some questions that I was kind of hoping to ask the group and this awesome group that joined on at 7:00 on a Tuesday night. But what's helped you stay healthy as a cancer survivor? What motivates you to stay healthy? What challenges have you faced? And could your medical team have helped offer you something that may have helped you? Or do you wish that they told you something or offered a program to you? What do you wish you could tell others that may have helped you? These are ways that you can send a message with this. You can reply in the chat. You can even just think about it. But these are ways that we may have the ability to do better in the future. I don't know if anybody has anything they wanted to share or any other questions.
I had red devil chemo and my heart rate was increased the entire 2-month duration of the chemo. And so I asked my oncologist, when do I get a repeat echo? Because they did one as a baseline before, to see if I could do chemo. And she said, oh, we normally do them like a year out. And I was like, a year? I didn't expect that long. And so I'm like, can we do one now? Because I was a little worried and I don't have any, heart disease or problems right now. But she did order the echo. And so I was very pleased that she, did one, or like it's the guy of everything, that she didn't just say, oh no, for a year out. So they did the repeat echo and it was okay. So that just made me feel better. And then once I switched to the Taxol chemo, then I didn't have the increased heart rate anymore. So, I was very pleased that my oncologist said, sure, we can do one now.
Yeah, good job advocating for yourself. But that we call it sinus tachycardia, or like a normal rhythm, but a high heart rate. That is a common early effect of the anthracyclines. Doesn't necessarily predispose you to having late dysfunction any more than anybody else. But always good to advocate for yourself when you notice a change. Your providers are usually aware of these things, and you should be always doing that. So well done to you on that.
No, thank you.
Back off of that, the importance of self-advocating. I can't say enough about that, but I think, you know, the second bullet there, what challenges have you faced, and asking your medical team. Some of you may or may not know, I am a cardiology patient, and I think my frustrations over the years have been not being heard or listened to when you share what you're feeling and what you're experiencing, and being easily dismissed. Oh, you look fine, you're a healthy young woman, whatever the thing may be at the moment. And it's very frustrating to you almost feel like you're crazy, because if you're not being taken seriously, then what are you wasting your time for? And it can be hard to advocate for yourself, but it's just so important. So don't give up on yourself.
I completely agree. And if you feel like a provider is not listening, it's never a bad thing to ask to see another provider, or to have them explain to you why they're not worried. Don't ever feel like providers are there to help treat you and also to help you feel better. And so if they're not doing that, then it's perfectly fine. Any good provider will be happy to have another person weigh in, or maybe think about another test, or go a little bit outside of the typical, and should be listening. So I completely agree with that. And I think there's a lot of people, you know, while childhood cancer treatment may be really familiar to all of us here, there's a lot of providers that have never taken care of a patient that's had childhood cancer treatment, is not familiar with these medications, may not be familiar with the guidelines. And so it's never a bad idea to ask and say, you know, have you ever taken care of a childhood cancer survivor before? Are you familiar with the guidelines for screening? Is there anything that I can help you? Or is there anybody that you recommend that I see that is familiar with it? Because you don't want to be dismissed or brushed off. Just like Baso said, people will, if you came and saw my clinic when I have cardio-oncology clinic on Thursday afternoon, it's the healthiest waiting room that we see all week in cardiology clinic. And so it's people that may be blown off by another cardiologist, not familiar with the risk that you bring to the table. And so don't ever hesitate. Those survivorship guidelines, like I said, it's a great website. You can even bring it to a provider to have them help understand better.
We have a couple more questions that came in.
Oh yeah. Let me open up the chat again. Okay, so long-term data on Zinacard use, Lauren asked, and another really great question. So there was a period of time that there was a hesitancy to use Zinacard, with the thought that it would decrease the efficacy or how well chemotherapy worked, and would potentially increase the risk of not treating the cancer, or of a relapse of cancer. That has all since been dismissed. There's good long-term data that Zinacard can help decrease cardiotoxicity. And at Children's and across many pediatric centers across the country, when you can use it, we do. Not all anthracyclines, depending on the way that it's administered, you can use it, but in almost every patient we have it, when it's available, it's used. And when it's in short supply, it's saved for patients that are going to have higher cumulative doses. But there's very good long-term data that it's helpful in preventing late toxicity. And the thought is that it can help kind of scavenge some of the free radicals that the anthracycline damage can do. Genetics that determine if survivors will be affected more than others post-treatment. This is a big area of research right now, collecting information on survivors going into it. And the most important thing is for us to look prospectively, meaning collect that genetic data and then follow outcomes so that we're less biased in how we view this. But there are certain gene mutations that can show that can predispose patients to having more severe cardiac outcomes. Right now, we don't know, and it's not widely done enough to say that that's a standard to be included in echo frequency or other things. But some people may be much more sensitive or may have early cardiac dysfunction. And for that reason, oftentimes their treatment may be adjusted a little bit. So there's a lot of research being done to figure out why those 4.4% or why those 10.6% of people develop heart dysfunction and the rest of people don't.
Well, I don't know if anybody has any other questions before we wrap up this evening. I really can't thank all of you enough for being here, for this topic being discussed. Thank you, Doctor, for being with us and lending us your expertise and answering so many wonderful questions. I hope everybody found this helpful and informative.
Yeah, thank you for providing this platform to be able to meet everybody and for picking this topic.
No, I was very happy that the road led me to you. So, but we will conclude everything this evening, and I will make this link to this presentation available so that you can revisit it or share it with others who could really benefit from it as well. And if you pop up with questions along the way, please don't hesitate to reach out. And if any questions come my way, should I pass them on to you, Dr. Rose-Felker?
Yeah, absolutely.
Okay.
Yeah, you can send them right to my email. And then I put on, we have a website. If you search for it, if you're interested in clinic appointments or other things, I'm more than happy. But yeah, any questions you have, send them along to me.
Okay. Well, thank you all very much. Have a great evening.
Thank you so much. You too.
Thank you. Bye-bye.
Thank you all for coming.
Bye.